So, uh, good morning, good afternoon, good evening, everyone. So thank you everyone for joining the ACNS YNS webinars. On behalf of Professor Kato, I would like to thank all of you for the expert speakers and also the audience for joining us today. So today our chair will be Professor Kimura Sensei, who is the Associate Professor of the Department of Neurosurgery of the Kobe University Graduate School of Medicine in Kobe in Japan. And we have three speakers today. The first expert speaker is Professor Liao Yujin, who will be talking about the surgical treatment of complex middle cerebral artery aneurysms, a single center experience. Our next speaker is Dr. Sam Suarvini, who will talk about the early experiences of Abdurrahman IMAX bypass for management of complex aneurysms. Our first speaker today is Professor Ashley Kuhn, who will talk about the microsurgical access to cranial dual AVM, how I do it. We have two discussions today. First is Professor Dushot, who is the neurosurgeon and the secretary of the Uzbekistan Association of Neurosurgeons, who is also the Republican Specialized Scientific and Practical Center University in Tashkent in Uzbekistan. And also our second discussion is Professor Ariel, who is a researcher in the field of evolutionary and developmental cancer biology of brain metastasis, and also founder and CEO partners in healthcare clinic and foundation of the underserved community in Albania. And also the former fellows in cerebrovascular surgery in Fujita, and also a former fellows in Barrow Neurological Institutes. So to moderate a section today, we have me, Dr. Ben, and also Dr. Sachin Atik, and Dr. Joey Sam, and Dr. Sukutik. And without further delay, shall I invite our chair today, Professor Kimura Sensei, to introduce our first speakers.
Okay, thank you, Dr. Ben and Dr. Raju. Nice to see you here again. Professor Yokkato, nice to see you again. Hello, everyone. Good evening and good afternoon. I'm Hidehito Kimura from Kobe University, Japan. It's a great honor again for me to chair this first session. I'd like to thank Professor Yokkato and Dr. Liu and Ben Raja. I'm very glad to introduce the first speaker, Professor Yujin Liao from China. Thank you very much for joining. He will talk about surgical treatment of complex middle cerebral artery aneurysm. I've been looking forward to hearing your presentation. So, Professor Yujin Liao, please start your presentation when you are ready. Thank you.
Thank you, Professor Camila. And good evening, good afternoon, every colleagues, and maybe good morning. And thank you, Professor Kato. And it's a great honor for me to share my experience here. Can you hear me?
Yes.
Can you see my PowerPoint?
Yes.
Okay, thank you.
The presentation mode, please. Yes. Thank you.
Hello, everyone. Today, my topic will be surgical treatment of complex middle cerebral artery aneurysm and with a single center experience. And I'm Dr. Liao Yujin, and from Shanghai, China. And I'm working with Professor Shibing in a same medical team. And this is where I'm from, Huashan Hospital in Shanghai, China. And we have several divisions in the city of Shanghai. And we have about 20,000 neurosurgical procedures every year. And we have around 150 neurosurgeons in our department. And today, my topic is about complex MCA aneurysm. And this is kind of vascular disease pose great challenge to neurosurgeons because of they are usually very large or giant and with a fusiform shape and with a broad neck, maybe no neck, make it unclippable. And sometimes the aneurysm will be dissecting or supine. And simply speaking, we have two primary concerns when we in the treatment of the complex MCA aneurysm. The first is how to preserve the blood flow of the distal artery, and the second one is how to preserve the perforators. Of course, we have several solutions like reconstructive clipping, maybe, and bypass with the trapping or the proximal or bilateral, and even distal occlusion of the aneurysm. And about 10 years ago, in our department, we proposed a new classification of the MCA aneurysm, mainly based on the location of the aneurysm. And the surgical strategies will be made according to the angio architecture of the aneurysm. And simply speaking, the left side is the more relatively simple cases, which could be handled with a clip or reconstructive clipping. And this in the middle cases, we can control the cases with bypass combined with clipping. But when the perforators involved, and it will be much more difficult to be treated. And about 5 years ago, and we also proposed another surgical strategies to treat the complex fusiform MCA aneurysm. And as you can see, the bypass is also still a main technique which would be used in the treatment of the complex MCA aneurysm. And the perforators still a very big problem for neurosurgeons. And for the protection of the perforator, we have several methods like the partial trapping or proximal occlusion of the parent artery, and sometimes even the distal occlusion will be used in the treatment of this kind of disease. And now let me come to some real cases to share our experience. And this is a case which could be treated with reconstructive clipping. And it is the M1 aneurysm. And luckily for this patient, the aneurysms inferior projected, and which with the perforators intact. And this is the ICA and A1 and M1. And several clips were applied for the reconstructive clipping of the neck of the aneurysm. And we can see the PCM and anterior choroidal artery were all preserved very well after the reconstructive clipping. And this is the outflow of the aneurysm, and which was confirmed by intraoperative ECG angiography and postoperative control CTA. And the aneurysm is totally obliteration with well-preserved parent artery. And this is another case, which will also giant MCA aneurysm, mainly involved the M1 segment. And as you can see, the distal part of the ICA was also involved. So, but luckily the perforators here, so we can use this clip line, and but we can only use some part of the aneurysm wall to to remodel the outflow of the distal blood vessels. And this is what we do during operation. This is the CTA post-operative. But sometimes we can only use this method. We will use several clips to make a clip line, like the case in the right side. And here's a video of one of our cases, a left side MCA aneurysm, mainly located in the M1 bifurcation with a large aneurysm size, but luckily the perforator is not involved. And after the dissection of the silver fissure, we temporal occlude the M1. And during the dissection of the aneurysm, and the bipolar could be used as a dissector, and sometimes a low power coagulation will be very useful for the remodeling of the aneurysm body and for a better surgical field. And by doing this, we can make the aneurysm shrinkage. Luckily for this patient, there's no branch or perforator originated from the dome of the aneurysm. And here also the low power coagulation of the aneurysm dome, and which can shrink the aneurysm and make some additional space for the further maneuver. And now all the outflow were identified. And now is the pilot clip. Now we are using a second clip. As you can see, the pilot clip can narrow the aneurysm and make some space for the second one. And in the end, the intraoperative Doppler to confirm the patency. And after operation, control angiogram indicated an excellent reconstructive clipping was achieved. And the patient was discharged uneventful. And sometimes we can use a combination of the two techniques with bypass and reconstructive clipping. As you can see in this patient, there are three M2 branches, and we can only reconstructive the third one. So the number 1 and number 2 could be only perfused by bypass flow. So we do the radial artery graft bypass first, and a second clip was used here to remodel the channel of the two M2 branches. And as you can see during the operation, this is the giant aneurysm, and this is the radial artery graft. And the MEP and the SEP monitoring indicated no abnormality during the revascularization in the end, compared with a baseline level. And CT angiogram after operation indicated the patency of the radial artery graft here. And as you can see, the anastomosis site intracranial here. And this is the number 3 M2 branch, which is fed by the proximal MICA and MCA. And now let's come to some more difficult cases, and in which the aneurysm is unclippable. So parent artery have to be sacrificed, sometimes bilateral, which is trapping, sometimes only one side, mainly on the proximal side. And after the sacrifice of the parent artery, the distal blood flow could be replaced by ECIC bypass, like high flow, medium flow, sometimes low flow is enough. And when no perforators evolved, and we will use trapping for the aneurysm, but usually the perforators would be evolved, especially for M1 segment aneurysm. And in this condition, in this situation, the perforators could be perfused by reflux blood flow from the bypass. And this is a real case, which is the left side M1 giant aneurysm. And clearly there's no neck of the aneurysm. So we use the radial artery graft for medium to high flow bypass. And this is the clip in proximal neck to occlude the proximal flow, and the entire MCA territory was perfused by the radial artery graft. And so is to the perforators originated from the aneurysm. And this is another case treated by bypass combined with proximal parent artery sacrifice. And this is a recurrent artery after initial embolization, and as we can see, severe edema around the lesion. And for this case, our plan was to bypass here for the blood flow replacement of the distal blood flow, and proximal occlusion in the ICA, because there's no space in M1. The aneurysm evolved the terminal ICA and initial MCA. But when we temporal occlude the ICA here in the neck, the MEP and SEP monitoring indicated some decrease. So we have to perform a staged occlusion of the ICA. And about 1 week later, when we totally occlude the ICA here, the patient, there's no signs of ischemic complication. So we just patently occlude the ICA in the neck. And this is the angiogram after operation. The ICA is occluded in the neck, and the bypass was patent. Also, the MCA territory was also irrigated by some blood flow from the beacon. And the aneurysms totally obliteration. And this is a lucky guy. And for this patient, our plan is to occlude or trap the aneurysm and combined with bypass. But as you can see the illustrative picture, this is actually an M3 aneurysm with very small distal branches. But during the operation, when we temporal occlude the proximal here, this is before, this is the proximal of the aneurysm, and the aneurysm here. And after temporal occlusion, the electrophysiological monitoring indicated no change compared with the baseline level. So lucky for this patient, we can just occlude the proximal of the aneurysm. And intraoperative ICG confirmed that no reflux flow into the aneurysm. And which was confirmed by postoperative CT angiography and DSA. And we can see the thrombosis formed rapidly after the operation. And this is a relatively rare used techniques, which is the bypass combined with distal occlusion of the aneurysm. And this technique mainly used, only used when the proximal neck is the proximal part is very difficult to expose, or sometimes the brain tissue is very fragile to be dissected, or even no space for clip for the permanent occlusion of the artery. And before the distal occluded, we have to confirm that the aneurysms have got a thick wall, like calcification or thrombosis. Because when we occlude the distal side, we will worry about the rupture risk. And after the sacrifice of the aneurysm, before the sacrifice, we will perform bypass, ECNC bypass, sometimes the STA-MCA, sometimes the radial artery graft. And in these cases, the perforator of the M1 segment was fed by the proximal blood flow from the heart. And this is a real case, M1 segment, irregular shape with some thrombosis aneurysm. And during the operation, we encountered with a very tight Sylvan fissure, and the brain tissue is very fragile. And so we performed the double barrel STA-MCA bypass. And about 1 week after the operation, control angiogram indicated a significantly shrinkage of the aneurysm. And this part of the MCA territory was fed by the double barrel STA-MCA bypass. And of course, we need a long-term follow-up for this patient. And this is another case with the same technology. And you can see the calcification of the aneurysm, and perforator originated very close to the proximal neck. So for this patient, our surgical plan is to clip the M2 the two M2 trunks here, the superior and inferior here and here. And the distal blood flow will be replaced by the double barrel ST-MCA bypass. You can see the calcification of the aneurysm. And during the operation, we actually do exactly as we planned. First, STA-MCA bypass, the anastomosis site is here around the M2 initial segment. And after that, we have to select a recipient artery. So we use the ICG angiogram after we temporal occluded the inferior M2 trunk here. And the ICG angiogram indicated a relatively slow blood flow in this cortical branch. So we selected as a recipient artery. And the second anastomosis was performed here. As you can see, this is the frontal lobe fed by the superior branch of M2. And in the end, the two anastomosis were performed and was patent confirmed by ICG angiogram. And in the end, angiogram confirmed the patency of the ST-MCA bypass, and with a relatively bigger diameter. And this is the angiogram of the left ICA. Actually, we can see the perforator proximal to the neck and distal, and at the outflow of the aneurysm, the perforators are kept patent. To be mentioned is that actually the flow in the distal part of the aneurysm is very slow. So it seems that the pressure inside the aneurysm was not so high, because when we close the distal part of the neck, we are concerned about the rupture of the aneurysm. But in this case, you can see actually the blood flows relatively slow, and so maybe the rupture risk will be no so high as we concerned. And this is another case also treated by the bypass combined with distal occlusion. I will skip the previous steps. And what I want to say is that when we occlude the parent artery, where should we bypass? And as you can see, we use the ICG angiogram at the baseline. I will skip this. I will go to here. Yes, this is the baseline, the left upper one, the baseline. And when we occlude the parent artery in the distal neck, this is bright, but the temporal and the frontal artery, frontal lobe is dark. So recipient artery will be selected at this site. One is here, and the other one is here. As here is the one of the anastomosis site, and here is another one. And intraoperative ICG confirmed the patency of the two bypass. And here's a very special case. And in this one, the aneurysm could be resected, and the bilateral end could be anastomosis. And this patient complained of headache, and CT scan indicated some hemorrhage. And this is actually a M2 to M3 aneurysm. And during the operation, we found the aneurysm is resectable, and there's enough space and for the re-anastomosis of the two ends. And this is the CT angiography post-operation here. And recently, we are using the hybrid techniques to treat this kind of MCA aneurysm. Let's take a look of a real case. This is the actually in the distal part of M1 segment, and because of the exchange the shape of the aneurysm, the diagnosis may be dissecting or maybe saccular aneurysm. And actually, maybe it can be clipped, but in three-dimensional reconstruction, it's very strange here, like pure arterial malformation. So we decide to bypass in the distal vessel network and coiling the aneurysm after the first stage operation. And the double barrel bypass was done, and about 4 days post-operation, DSA confirmed the patency of the double barrel bypass, the anastomosis site here and here. And the aneurysm still here. So we used 2 coils for the coiling of the aneurysm, but only partially coiling. As you can see, there's still outflow from the aneurysm. But the flow is very slow after the partial embolization, especially in the lateral view. And now the angiogram of the left ECA indicated a significantly growing of the STA, both the 2 bypass, compared with just maybe half an hour ago. And the aneurysms almost obliterated, and the perfused area of the bypass getting enlarged compared with the pre-coiling level. This is a small summary of this case. This is pre-coiling in the left side, the left ICA and left ECA angiogram. In the middle is a picture of the coiling of the aneurysm, and this is the post-coiling. In the end, almost the entire MCA territory was perfused by the double barrel bypass, and the aneurysms almost obliterated. Of course, we still need a long-term follow-up for this patient because there's still some residue of the aneurysm. And this is the last case, and it's very interesting also. And left MCA, maybe M1 bifurcation aneurysm, and with some thrombosis with giant size. We also performed a double barrel STA MCA bypass here. And this angiogram in the lower 3 pictures was done 7 days after the operation, and we can see the aneurysms shrink very much compared with preoperatively. And for this case, we even the coiling was unnecessary. The aneurysm was getting small very apparently. And let me make a small discussion of the last two cases in terms of hemodynamics. Speaking of blood flow competition between the bypass and initial flow, in case 2, let's see this case. Here's a large aneurysm in the MCA. So the turbulence inside the aneurysm would cause great energy loss. So the perfusion pressure in distal vascular is very low. And after the bypass, the balance point between the bypass and initial flow, maybe here, just around the aneurysm. And the thrombosis inside the aneurysm was accelerated. So only 7 days after the operation, the aneurysms shrink very much compared with operatively. But the first one, the aneurysm is relatively low. So maybe the balance point here after the bypass. And when we coiling the aneurysm here, and we change the power of the two blood flow, and the balance point went more proximal to the aneurysm, and the aneurysm is obliterated. And now let me make a small summary of my topic and difficulties and we can be encountered in the treatment of MCA complex aneurysm, distal artery, and the perforators, and we can use several methods to follow solution of these problems. We can use bypass to follow blood flow replacement of distal artery, and which procedure will be better? Maybe the NOVA or the CBF measurement could help us to follow surgical decision. And ICG angiogram could help us to select a proper recipient artery during the operation. And speaking of the protection of the perforator, and usually involved in M1 segment, and we can use several methods to keep the blood flow. The perforators will be fed by distal blood flow or proximal blood flow, sometimes combined with the staged occlusion techniques. And as well to the aneurysm, we can use the trapping, proximal occlusion or distal occlusion for to deal with the dome of the aneurysm. And the last case indicated that maybe sometimes a conservative method, just wait and see. Maybe several days later, a delayed thrombosis in the aneurysm will help us. And even coiling will not be necessary. And now it's my conclusion. And for this kind of complex MCA aneurysm, reconstructive clipping still our first choice because it's simple, effective, and we can preserve the normal anatomy. And bypass technique is commonly used in the treatment of this kind of disease. And perforators are very important. We have several techniques to preserve the blood flow of the perforators. And during the operation, the MEP and SEP monitoring will be very helpful in choosing a proper surgical modalities and strategies. And favorable outcomes can be achieved by various surgical techniques based on morphology analysis. And in the end, I want to say is the pressure change induced by the bypass, by the blood flow competition may have some effect on the thrombosis inside the aneurysm and maybe induce or accelerated the thrombosis process inside the aneurysm. So a bypass combined with or without a proximal coiling maybe a simple and effective way to treat the complex M1 aneurysms. And now it's all I want to say, and thank you very much for your attention, and welcome to visit us in Shanghai. Thank you for your attention.
Thank you. Sorry. Thank you. Thank you, Dr. Yao. So very fantastic cases, surgical cases. So surgical technique is excellent. No need to say. So very difficult cases you shared with us. So you mentioned about the very important concept to use a bypass surgery in treating the complex cerebral aneurysm, especially in distal clipping prior to the bypass surgery is very, of course, important concept. So maybe there are very complex cases. So final decision how to manage each aneurysm is up to the patient condition, the aneurysm condition, location and size, I guess. So very nice surgery. I was so fantastic and surprised, impressed.
Thank you.
Yeah.
Thank you, Professor Camilla. Thank you for your comment.
So please give us some comment from Professor Dr. Derishud. Do you have some comment?
Yes. Thank you so much, Dr. Liao and Kimura Sensei. That's a pleasure to join this wonderful series again, especially today's topics mostly vascular. So I saw Dr. Liao's presentations is mostly dealt with the complex MCA aneurysms, mostly using by low flow bypass for the cases where revascularization is needed. My question is, were there any cases that you needed to use a high flow bypass to revascularize in complex MCA aneurysms? Do you have such cases, or because you use double barrel bypasses, this is enough for enough cerebral blood flow?
Yes, thank you. Thank you, Professor, for your question. Actually, we also use the high flow bypass, especially in our early cases, and we often use the radial artery graft. And but more recently, we found maybe the double barrel bypass normally could provide enough blood flow for the MCA territory. But in some particular cases, like women patient, because the STA is relatively small, smaller compared with male patient. So in this kind of case, we will consider the high flow bypass, as you mentioned. Actually, I have several cases in my PowerPoint. We use the high flow bypass with radial artery graft. Yeah, but I think maybe high flow is very complicated, and if we can handle this problem with a more simple way, we prefer the double barrel bypass of STA.
Yes, always from simple to the complex case. Yeah,
yes,
that's very reasonable. Thank you.
Thank you.
Very good question. So double barrel bypass is usually a good supply to the entire MCA territory you mentioned. So your recommendation is first choice to perform the double barrel anastomosis over the high flow bypass, right?
Yes.
Thank you. Yeah, good comment. Yeah, thank you. So Dr. Ben, do you have some comment? Thank you.
Yes, and First of all, I would like to congratulate and thank you, Professor Liu, for your great case sharing and really impressive surgical results. And congratulations. And so I have several questions to ask. The first one is about in case have you ever encountered cases that those small lenticle striae that might need to be sacrificed? Because there are also reported case that sometimes they need to do lenticle striae bypass. Do you have any experience with that? And other question is about usually for your intraoperative monitoring, how long would you wait after the temporary clipping to wait for the MEP and SSEP to see if there's any changes? And my third question is about in your last case. So very interesting case about the aneurysm thrombosis due to the blood flow competition. But will there be any worries about the thromboembolism from the aneurysm? Will you give any antiplatelet in that case? And yes, and thank you very much. And again, thank you a lot for your great case sharing.
Thank you, Professor Ben. And you have three questions. The first is the bypass of perforator.
Yeah.
Yeah, sorry, we don't have that kind of experience.
I see.
Maybe too small, and maybe we can try later. Thank you for the question. And the second one is how long to decide whether to bypass or not. And actually, normally we will perform the bypass. And if normally the duration of the temporal occlusion is 15 minutes. And just like the case I mentioned, in the end we use the staged occlusion of the ICA because after the bypass with I think is the radial artery high flow, and we believe the abnormality of the SEP and MEP is because of the perforator. So we have no other way to add more flow to that. So we can use a staged occlusion to wait a delayed formation of the collaterals. So I think maybe it's a way. And the other method is to like the distal aneurysm, like the M2 or M3 aneurysm, we can use intraoperative DSA to confirm the whole hemisphere. If there's no how to say delayed perfusion area or the absence perfusion area, we think maybe collaterals enough, so it's okay. And the last question is how to manipulate the thrombosis, make it happen inside, just acutely inside the aneurysm. That's what I want to know. Maybe we can talk about. I think maybe the pressure measurement wire would be a choice. We can insert the pressure measurement wire inside the aneurysm body, and baseline and post-operative or occlusion proximal or the distal, and we can measure the change of pressure inside the aneurysm. Maybe can tell us how to do. Yeah.
Can I ask a quick question about the last case? Do you need to give antiplatelet, for example, aspirin or Plavix in your case?
No.
No need. I see.
But it's only our single center experience. Maybe some.
I see. Thank you. Thank you so much.
Thank you.
Thank you. So I just want to make sure you don't have never to use antiplatelet drugs preoperatively to the patient, such kind of complex aneurysm patient.
Yes, Professor.
Sure.
We almost no use the antiplatelet drugs. Yes.
Thank you.
Thank you.
So please, Raja, you have some comment.
Yes, of
Thank
course.
you.
First of all, let me thank Eugene for this wonderful talk. Always a pleasure to hear and learn from you. Regarding because it is MCA aneurysms, I would like to say that these aneurysms are one of the most beautiful aneurysms that you have in with regards to the ideal clip configurations. So the ideal clip configuration, which amounts to the ideal line of closure to achieve in a bifurcation aneurysms, because once you clip there may be some remnants. So with one single clip it is difficult to obtain an ideal line of closure. An ideal line of closure is a perpendicular to a parent vessel in bifurcations aneurysms, whereas it is parallel to a aneurysm in a trunk aneurysms. So and also the ideal line of closure should restore the original anatomic configuration as well as eliminate the aneurysms fully as far as possible. So have you any specific clip configurations? Because what I usually clip the MCA aneurysms with two clips. One is straight clip with a right angle fenestrated, or a right angle clip with a straight fenestrated. So this restores the most anatomical configuration. This is after I read an article described by this ideal concept line of closure from Naoki Nakayama in Hokkaido, Japan. So do you have any specific ideal line of closure or specific clip configuration for MC aneurysms?
Thank you for your comment, Raja. I beg your pardon of your question.
No, do you have a specific clip configuration to use in MCA bifurcation aneurysms?
You mean
Like,
specific clips I preferred to use?
yeah, which
or,
clips do you use, the patterns? Like, is it a tandem clipping or a intersegmental clipping? Do we have any specifics?
Actually, I prefer the simple ones.
Simple one.
Straight or a little curved and long. If I can handle totally occlude the neck of the aneurysm, I think the more simple is the better. This is my my opinion.
I think
Doctor,
yes.
no, sorry, Dr. Raja.
Yes,
So I think
yes,
the closure line, you mean the closure line, I think it's up
closure
to the,
line.
yes, up to the aneurysm wall property. If the wall is so thick or sometimes very thin, so up to the wall, I think. So then you can decide during the surgery.
I agree. Thank you, Professor.
Thank you, Sensei.
Thank you.
And do you still use the Professor Shubin's modification of the Silverstone clamp for proximal neck aneurysms?
You mean the proximal staged occlusion?
Yes. Professor Shubin modified it, the Silverstone clamp.
Modified. Yeah. Now we prefer the new one, modified by Professor Shubin. Yes.
Okay. Thank you very much.
Okay, Dr. Sam, do you have some comment question? Dr. Sam?
Thank you, Kimura Sensei. Thank you, Prof. Leo. It was very fantastic cases you shared. I would just like to ask whether you have had experiences where preoperatively the diagnostic angiogram shows as if there are many perforators coming from the dome. But at times when I plan for the surgery and when we enter, actually the perforators are not coming from the dome, but they're just very closely adhered. I'm just wondering whether there are ways or there are any special techniques where preoperatively you could already tell that they're just closely adhered and not really coming from the dome, so as to avoid how to say it, overdoing. Instead of doing a bypass, could have just clipped the aneurysm or reconstruct it, that's.
Yes, thank you. Thank you for your question. Actually, I also have this kind of concern actually, but sometimes we have to go inside and finally we can know whether perforators directly originated or just pass through. So I think no matter which kind of the situation we can handle with the blood flow. So I think it's not so important to understand the exact anatomy before operation. So because I think there may be so many factors will make us to change our surgical plan during operation. So I think we have several methods, perfused the perforator by proximal or the distal reflux flow bypass, and even with the staged occlusion. So we can wait for the formation of the collaterals. So I think these techniques are more important than just the recognition of the perforators. But I think you are right. If we can do before operation, that would be much better. Thank you. Thank you. This is my understanding of your question.
Okay, thank you. Thank you. I think my internet got cut off for a short while just now, but yeah, thanks for your answer.
Thank you.
Thank you. So due to the time limitation, so can I accept another comment? Yokokato, it's okay. Okay.
Yes,
Okay.
please. Yes.
Okay. Okay. Please, and Dr. 𝑣𝒂𝒂𝒏, do you have some comments? Thank you.
Sensei, Kimura Sensei Kato, thank you. Actually, I'm present fellow at Fujita. I have a few questions. It was an excellent presentation. Professor, you showed a dissection of the dome with bipolar. How much bipolar current you use in this case? And about one case, the hybrid approach you have used, the M1 bifurcation aneurysm. I just want to ask, was it coilable at first hand, or if it was not possible to coil, why wouldn't you go for the clip rather than for the hybrid procedure? Thank you.
Thank you. Thank you. Thank you for your question. The power of the bipolar is around 3 watts, 3, and depends on the situation of the vessel wall. Sometimes maybe 5, sometimes maybe 2, but start from very low power. This is my experience. And the other question is do we use the hybrid technique as routine or what? Normally we use the staged operation. The first we bypass, and several days we coiling the aneurysm. Sometimes coiling the aneurysm with the parent artery only partially, not totally, and wait for delayed thrombosis of the aneurysm. I don't know if I answer your question.
Actually, why not do it at first? I mean, in single
same
setup.
time?
Yeah, single time.
Yeah, at the same time.
Yeah. I mean, at single setup, if we're doing bypass, do clip and then do the bypass. Or if we're doing coiling, do it 100%, because you do the DSA, whether there is a distal flow or not, you can easily confirm with the per procedure DSA.
Yeah, thank you. Because we have some experience, and after the bypass, if we just wait and do nothing, maybe the aneurysm will shrink several days later. So there's coiling, the second staged coiling won't be necessary. This is first reason. And the second one is the hybrid OR is not always available for us. Yeah. Yeah.
Okay, thank you, Professor.
Thank you. Thank you.
Wonderful cases.
I think at the same time it's also very reasonable to reasonable at the same time bypass and coiling.
Thank you. Very valuable comment. It's a very valuable, meaningful discussion. Thank you for sharing your experience and comment. Thank you. So it's time, due to the time limitation, I just want to move on to the next speaker. So sorry for another comment. So next speaker is Professor Arifini. He will talk about the early experiences of Abdullah IMAX bypass for management of complex aneurysms. Okay, please start your presentation. Thank you.
Can you see my screen?
Yes.
Yes, thank you. Respected Professor Iyoko Kato Sensei, respected organizers of ACNS, learned neurosurgeons from home and abroad, good afternoon, good evening. I'm Mohammad Shamsul Arifin from Bangladesh. I would like to share my early experiences of Abdullah IMAX bypass for management of complex aneurysms. For management of complex anterior circulation aneurysms, usually ECIC bypass is done, and for those cases, common donor is external carotid artery or common carotid artery in the neck, and for that purpose, we need a big radial artery or saphenous vein graft along with a big neck incision to minimize the length of this graft and minimize the length of this neck incision, or to avoid it, there is another option is internal maxillary artery as a donor. And in 2011, first published, Professor Selim Abdul Rauf and his team first did a internal maxillary artery M2 bypass for managing a case of fusiform aneurysms. We know that there are two terminal branches of external carotid. One is superficial temporal artery and another is internal maxillary artery. And this maxillary artery has again three segments: mandibular segment at the region of neck of mandible. Mandibular segment, pterygoid segment. Pterygoid segment that lies in relation to the either medial or lateral to lateral pterygoid muscle, and another is pterygopalatine segment in the pterygopalatine fossa. The distal portion of this pterygoid segment or pterygopalatine segment is usually utilized as a donor for IMAX bypass, and for this region, internal maxillary artery need to be exposed, and there is two methods for exposure of this maxillary arteries documented in articles. One is anteromedial approach. In these cases, after frontotemporal craniotomy, middle fossa floor at the region of foramen rotundum, anterior to it and lateral to it, is drilled out to find out the internal maxillary artery at the level of pterygopalatine fossa and brought it in the middle fossa, and then do it end-to-end bypass. But this part is tedious as well as very demanding technically. But another approach is documented or mentioned in the literature. Anterolateral approach. In these cases, a line is drawn from the foramen rotundum to foramen ovale, and lateral to it, the bone is removed from the infratemporal crest to that region, so that a distal portion of the pterygoid segment as well as pterygopalatine segment all can be exposed, and this type of exposure is required for end-to-side bypass as well as end-to-end bypass. Both are easily doable. From 2021 to 2024, from this during this time, I did 7 IMAX bypass. That is internal maxillary radial artery end-to-end bypass 2 cases, internal maxillary radial artery end-to-side bypass 4 cases, and 1 case was utilized for managing a case of basilar top aneurysm giant. So this is the first case, 15-year-old boy presented with headache, partial ptosis on right side as well as disconjugate eye movement. There is a large cavernous IC aneurysm on right side, and we planned for IMAX bypass. So we have to evaluate the diameter as well as the location of the internal maxillary artery. So CT angiogram provides the location of the maxillary artery. This is the lateral pterygoid muscle, and it lies lateral to it. If the 𝑖𝒓𝒄 is lateral to lateral pterygoid, it is easy to dissect. So this is the exposure. Right frontotemporal craniotomy, zygomatic osteotomy, and after that we did this bypass. And the middle fossa floor need to be removed. In the anterolateral exposure, that is from infratemporal crest to the region of foramen rotundum and ovale, the whole area is removed. So this is the operative video. The radial artery was harvested simultaneously along with neck and head exposure. For 𝑖𝒓𝒄 bypass, about 8 to 10 centimeter males need to be harvested. Infratemporal fossa is exposed. This is the lateral pterygoid muscle. And for better exposure of the 𝑖𝒓𝒄, infratemporal fossa retromaxillary backplate need to be removed partially, and the cranial attachment of the pterygoid muscle need to be partly sacrificed, and this muscle need to be retracted backward. So this is the internal maxillary artery, which is auscultated, flow ensured. And along with 𝑖𝒓𝒄 bypass in all cases, except the last one, I did STMC, either single barrel or double barrel bypass. So after preparation of both STA, dura was opened, and severe fissure was immediately opened to find out the appropriate M3 recipient for 𝑖𝒓𝒄 radial artery M3 bypass. So M3 is prepared, and on the frontal side, on the temporal side, the 2 M4 is prepared. Frontal branch of STA and temporal M4 anastomosis is going on with 10 or 9. After lateral wall suturing, medial was also sutured and bypass completed. After frontal STM4 bypass, parietal STM4 bypass was also completed. And after completion of both bypass, now the 𝑖𝒓𝒄 bypass. For that, radial artery was prepared, which was previously distended, pressure distended to avoid vesicous spasm. Arteriotomy of 𝑖𝒓𝒄 was done, and this is the benefit of end-to-side 𝑖𝒓𝒄 bypass. The mismatch of 𝑖𝒓𝒄 radial artery can be avoided. Ectopoly is utilized for this suture. First lateral wall is sutured in continuous fashion. After completion of the lateral wall, the radial artery was slit, and medial wall was repaired in the same fashion. So this is the flow from the 𝑖𝒓𝒄 to radial artery. After initiating the flow, it was slipped, and the final bypass. So preloading of the radial artery with ectopoline was done to minimize the ischemic time. Head stitch and then toe stitch. First lateral wall, utilizing the same suture, continuous fashion. Medial wall also sutured. So after ensuring flow of all 3 bypasses, STMC double barrel and 𝑖𝒓𝒄 radial artery M3 bypass, IC was ligated neck. So this is the immediate post-op CT angiogram revealed 𝑖𝒓𝒄 radial artery into side bypass and 𝑖𝒓𝒄 M3 into side bypass. And this is STMC double barrel bypass. Patients did very well in the post-op, and the post-op DSA showing the whole MCA tree is covered by STMC double barrel as well as 𝑖𝒓𝒄 bypass. This is a case. This is my first 𝑖𝒓𝒄 bypass. This is a case of complex supraclavicular IC aneurysm with pre-aneurysm stenosis and post-aneurysm significant vesicous spasms. I didn't try clipping this case. I did STMC by double barrel bypass as well as 𝑖𝒓𝒄 radial artery M2 bypass. This is the angiogram. The 𝑖𝒓𝒄 was oversized, limb as a first case, and 𝑖𝒓𝒄 is robust, and patient did very well. This is a case of 39-year-old male, left paraclinodal IC aneurysms. And for this case, we did 𝑖𝒓𝒄 radial artery M2 bypass. And in this case, we did end-to-end bypass, end-to-end anastomosis between 𝑖𝒓𝒄 and radial artery. For end-to-end anastomosis, there is one benefit is radial artery, 𝑖𝒓𝒄 can be brought superficially, and it can be dissected from intertemporal fossa. So bypass becomes superficial. So this is the cut flow of 𝑖𝒓𝒄, and this is the radial artery. And in this case, we occluded ICA at the level of Glasgow triangle. So it was drilled and ICA was exposed for feature bleeding after bypass. So end-to-end 𝑖𝒓𝒄 radial artery bypass was done in interrupted fashion. This is the flow through the radial artery graph, and then 𝑖𝒓𝒄 M2 bypass was completed. After completion of bypass, flow was checked, and completion of STMC and 𝑖𝒓𝒄 bypass, Petrus IC was clipped at the Glasgow triangle. So this is the immediate post-op scan. ICA as well as aneurysm abolished completely. 𝑖𝒓𝒄 bypass and STMC bypass all are patent, but there is a stump. So this is the drawback of Petrus ICA clipping. And this stump, if is more than 1.5 centimeter, it may cause future thrombosis via the ST and radial embolization. This is a case 55 years old lady presented only with headache, and image shows there is a giant aneurysms, thrombosed aneurysms, and partially supraclavicular ICA. This is the giant lips, supraclavicular partially thrombosed ICA aneurysms. This portion is dead, thrombosed, and this portion is live. And for this case, we did 𝑖𝒓𝒄 radial artery M3 bypass as well as STMC double barrel bypass. This is site of craniotomy. This is the zygomatic osteotomy. And immediate postoperative period, aneurysm becomes thrombosed. This is the postoperative CT angiogram showing 𝑖𝒓𝒄 bypass is well functioning as well as STMC bypass. So patient did follow-up at the time of stitch removal. This is a ruptured case. The badly ruptured case, 55 years old female, present with subarachnoid hemorrhage, ICH with ventricular extension, continuous grade 3. In the preoperative patient status, patient could open eye, but could not follow any command. This is the this is the CT angiogram preoperatively. This is a giant supraclavicular left-sided aneurysms with multiple blips. In this case, and there is a bigger maxillary artery on this side, as well as ST is not that much bigger. So in this case, we did left-sided 𝑖𝒓𝒄 radial artery M3 bypass as well as STMC double barrel bypass. In the immediate post-op scan, aneurysm is thrombosed, and postoperative angiogram showing all the bypasses are well functioning, STMC double barrel as well as 𝑖𝒓𝒄 bypass. And the postoperative DS is showing the right ICA supplying the S up to ACA, but total MCA tree is covered by all the bypasses we have done. And retrogradely via MCA, the ICA is also filling, but aneurysm abolished completely. So this is the STMC double barrel, and this is the 𝑖𝒓𝒄 bypass, and retrogradely ICA is filling, aneurysm is abolished. This is the lateral view. All the bypasses are well visualized, and before discharge, patient could follow command. This is another patient, ruptured subarachnoid hemorrhage, continuous grade 2, and this is a case of IC terminus aneurysm on right side, and we did in similar patient we did right-sided 𝑖𝒓𝒄 bypass, STMC single bypass. This parietal branch kept in continuity. This is the postoperative angiogram. In this case, aneurysm didn't thrombose, but reduced size a bit. But the IC is abolished, and terminal aneurysm is converted to sidal aneurysm. We're expecting with time it will get thrombosed or reduce in size. This is my last case, unfortunate case. This is a case of giant basilar top aneurysm, partially thrombosed. This portion is only active, but this aneurysm could not be clipped. So plan was to do bypass in the PCA circulation from the 𝑖𝒓𝒄 and then clip the basilar artery below the SCA. So we did it. This is the 𝑖𝒓𝒄 infratemporal fossa. This is the cut flow of 𝑖𝒓𝒄, and this is the radial artery 𝑖𝒓𝒄 end-to-end bypass. And this is the PCA. This is the brainstem, the P2 segment, and this is the radial artery PCA bypass. And after this all done in the transsylvian corridor, the subtemporal corridor, we clip the basilar artery below SCA. With the post-op scan, and the clip at this place below SCA, aneurysm decreased in size, and bypass is also functional, but patient didn't survive the procedure. So at the end of 7 cases, out of 7 cases, 5 patients doing well without any aneurysm at present. 1 patient is doing well with aneurysm still live, maybe decreasing in size, and 1 patient didn't survive the procedure. So in conclusion, I'd like to say scope of microvascular bypass in neurosurgery is extensive, and surgical outcome is quite satisfactory in my limited series of 7 cases. Strong motivation, perseverance, lab practice, proper guidance, and opportunities required to be a microvascular bypass surgeon. Thank you very much.
Thank you. Thank you, Professor Arifini. So very, very fantastic bypass. So I've heard ever about regarding this IMAX bypass just using the internal maxillary artery. So very, very fantastic technique. In maybe I think the alternative technique using our standard high flow bypass, EC-IC high flow bypass. In such a case, even I can't find out the appropriate ECA. So basically, it's maybe a good chance to alternative method to high flow bypass to perform. Thank you very much for sharing. So my first question is, why do you perform the double barrel anastomosis prior to the IMOX bypass or to all cases? Do you select?
In almost all cases, I did at least single STMC bypass, except the posterior circulation cases. The main reason is that STMC bypass is an insurance, as well as it rarely occludes. It rarely occludes. So when we use a graft, interpositional graft, there is always some sort of chance of occlusion, per procedural or post-procedural. But STMC bypass rarely fails, even maybe never fails. So in 1 or 2 STMC bypass, I usually do.
I see. Yeah, thank you. Dr. Raja, please give some comment. Thank you.
Yes, Samsul, excellent, excellent. I'm really
Thank
proud
you,
of you. It is fantastic that you have showed. Regarding the ruptured cases I saw, so when do you give heparin to them in a case of ruptured aneurysm? Because it is very, very high risky case when you have not secured the aneurysm,
yes,
which is ruptured, and you are giving heparin. So do you give at all, or when would you recommend it?
Actually, per operative heparin around 5,000 unit, but in all cases, I never crossed the more than 2,000 unit heparin. So half the dose of requirement is given, and it was given usually at the time of just prior to starting of anastomosis, both STMC and IMAX radial artery or MC. So per procedure, there is almost 2 hour. The operative field is in front of you. So it is given prior to starting of bypass, so that if anything happens, it happens in front of you.
So you have it in the back of your mind that it is a ruptured and you are giving heparin,
Yes.
but you can control it as and when it happens.
Yes.
Okay, thank you very much. So Ashish has raised his hand, I think.
Thank you.
Thank you. Excellent cases, Dr. Arifin. I think not many people do IMAX to MCA bypasses. And I think it's important to know that these indications, like certain indications, still exist. I wanted to ask, like for ruptured cases, I understand that you don't have much options. You cannot do any other, stent-assisted procedure for endovascular treatments. But for unruptured cases, for example, the first and the last one which you showed, I understand that there will be sometimes a problem with financial constraints as well with these patients. I've seen it myself, but any kind of inclination towards doing a balloon test occlusion and do a simple, parent vessel sacrifice versus, if needed, use of any kind of flow diverting stents in unruptured cases, especially when there is a mass effect. So sometimes that procedure will, help to reduce the mass effect without the need for surgery. And this is especially for posterior circulation aneurysms, the unruptured ones.
Actually, most of the unruptured cases we get referred from our intervention colleagues. For financial constraints, people can't afford it and they are sent to us. But rupture cases, we both get directly and indirectly.
Okay. Yeah. So financial constraints become a major part of the
Major part,
decision making. Correct.
Yes.
But anyway, excellent presentation. I think the other thing which I wanted to know, if you have neurophysiology at your center to kind of guide your temporary occlusion time, especially when you're doing.
In my center, we have, but it
Perfect.
is multiple theater is ongoing, so it is rarely we can avail it in our vascular cases. Rarely. In carotid endarterectomy, we actually try it, but in aneurysm cases, it is rarely done.
Okay. Thank you. Excellent cases.
Thank
Thank
you.
you.
Excellent. Fantastic comment. Thank you. So, Professor Ericon, do you have some comment? Can you give me some comment? Give us. Thank you.
Dr. Arifin, it's a wonderful series you presented. I thank you very much for being here with us today. It's a brave undertaking. Dr. Kumar is right. You don't see often the use of IMAX into the field of bypass surgery. We had earlier Dr. Liao presenting a wonderful series from a center of reference, actually, showing how they use various trapping methods to then reconstruct the flow. But you have remained loyal to your mentor, Dr. Abdul Rauf, in your cases. And
Yes, sir.
yes, I thank you for bringing your series today with us. It's difficult to see these cases, and a good reminder. Congratulations on your wonderful work, and I hope it grows to the extent of improving the technique and the problem that you had with your last case. It's basilar tip is always going to remain a challenge in vascular surgery.
Yes.
Please let us know what progress is next when you see that.
Sure, sir.
Thank you so much.
Yeah, thank you. Very difficult cases, and you did so excellently operate. Yeah, fantastic. So my final question is how to find out the internal maxillary artery after drilling the middle fossa. Is it easy to find out the vessel artery?
Yes, it's not difficult, sir. First, there are various methods explained in literature to find out the IMAX. One is to find out the deep temporal artery, press it down, and find out the IMAX. One is to trace the middle meningeal artery from spinosum and trace it down to IMAX. But the easiest one I follow to find out the pterygomaxillary fissure. IMAX always goes through the pterygomaxillary fissure to pterygoplateal fossa. So why don't you find it there and press it back to get a big caliber for bypass? So first drill the middle fossa floor, find out the lateral pterygoid muscle, retract it medially if it gives you any difficulty, detach it from the roof, and then you will find the retromaxillary fat pad in between lateral pterygoid muscle and temporalis muscle. Remove the fat pad and you will get the artery.
Yeah, I see. I will try the next cadaver dissection. Thank you.
Sure.
Dr. Ben, do you have some comments? Thank you.
Yeah, just a quick question. And I would like to ask about, I saw that you may need to cut the pterygoid muscles. And so any problem with the mastication function of the patients, and also any problem with the trigeminal nerve functions? Thank you so much.
Actually, in initial cases, there is epidural peeling. I did epidural peeling to find out the V2, V3. But in the later part, I understand that too much medial exposure is not required at all. So you don't need to identify the V2, V3, expose them at all. So just find out the foramen rotundum, find out the foramen ovale. And another thing is lateral pterygoid muscle has two attachment, upper attachment and lower attachment. Lower attachment attaches with the lateral pterygoid plate, and upper attachment is attached to the infratemporal fossa crest and medial to it. So an upper attachment is smaller than the lower. So if you remove it, in my series, I didn't find any chewing difficulty or anything else.
Thank you.
Thank you. Thank you. Thank you.
Thank you.
Fantastic comment. Yeah. Okay. Now I just want to move on to the next speaker. So it's okay. So next speaker is Professor Ashish Kumar. He will talk about the microsurgical access to cranial dural AVF, how I do it. So please start your presentation. Thank you.
Thank you so much. I hope you can see my screen.
Yes.
I'll be presenting, I will say, the least technically challenging topic of the day, because I've seen the MCA bypasses and I've seen the IMAX bypasses. My topic is relatively straightforward, and I will say the least technically challenging, but there are some nuances to it. So I'll be discussing about microsurgical access to cranial dural AV fistula, and I'll be showing some case-based examples as well. So I work at Sunnybrook Health Sciences Center at University of Toronto, and I am a dual-trained hybrid cerebrovascular surgeon. Part of my training in 2010 was at Fujita. So thank you, Professor Kato, for helping me reach where I am right now. So this is my hospital. This is one of the largest trauma centers in Canada, and a 1,500-bedded hospital. Sunnybrook Hospital was initially started in 1948 as the largest veteran hospital in Canada, and now it has transformed into largest trauma center in Canada and one of the teaching hospitals at University of Toronto. So as I said, today, learning objectives, I will briefly underline the types of cranial dural fistula, because this is important to know your surgical techniques. I will also go through recognition. I will also go through the natural history and different types of dural AV fistulas, just a brief mention of classifications, and then I will come to the microsurgical access to cranial DAVFs, and this will be discussed by case-based scenarios. So we all know this, dural AV fistulas can be cranial and spinal. Today, I'm not focusing on spinal, but cranial dural AV fistulas can be most commonly seen across transverse sigmoid sinus and supraparietal sinus. They can be seen across anterior skull base, and they can be also seen as direct and indirect CCFs or carotid cavernous fistulas. Now, when we talk about dural AV fistulas, the first thing which comes to mind in today's world is endovascular treatment. So endovascular treatment has become the frontline treatment for dural AV fistulas, but is microsurgery still relevant? So pathogenesis of cranial dural AV fistulas are basically secondary to etiology like post-trauma, post-thrombosis of supraparietal sinus, or sinus thrombosis of the transverse sigmoid sinus, or a previous craniotomy which has initiated a scarring of the sinus. Anything which can cause slow obliteration of the transverse sigmoid sinus. As we can see here, there is a stenosis in the transverse sigmoid junction, and you can see then it slowly initiates the vascular factors release from the nearby extradural vessels like occipital arteries, and then that will initiate the generation of anastomosis between the ECA and the sinus components. So that leads to the flow, which starts to flow back to the venous sinuses and resulting in what we call as CVR. The natural history is pretty significant. So probably the risk of rupture or hemorrhage from a cranial dural AV fistula is highest, more than an aneurysm as well. As you can see here, the risk is in important type 2 or type 3, which is involving significant corticovenous reflux or CVR. The risk of mortality is around 10%. So what is Borden classification? There are two classifications which we use to define dural AV fistulas, because your treatment is based on the type of classification. The most commonly used is Borden classification, where type 1, type 2, type 3 dural AV fistulas are encountered. Type 1 is labeled as benign because the flow is always antegrade. So you can see on this side, there is fistulous formation between the external carotid supply, like from occipital artery into the sinus, but then the flow is towards the antegrade direction. So it's not coming back to the brain, hence this is benign, and this will always lead to most likely tinnitus or any pulsatile sound which patients can hear. But as there is no CVR, we leave it alone. Type 2 and type 3 are called as aggressive ones, where you can actually see the sinus is now filling retrogradely and the blood is going back to the cortical veins. And that creates a high pressure system in these veins. And that's why the highest risk of rupture. Type 3 is where you can see that the MMA is here, or the extradural arteries. They actually form direct connection with the veins and there's no involvement of the sinus. So if we see type 2 or type 3, which are called as borderline type 2 and borderline type 3 fistulas, that tells you that there's a direct connection or indirect connection from the arteries to the venous side, and that has actually led to what we call as venous hypertension. So all the arterial blood is refluxing into the sinuses, and that causes a lot of venous hypertension and hence the risk of bleeding. So the basic investigations, DSA remains the gold standard. MRI will show signs of venous hypertension, as you can see here. And you will see multiple flow voids, either across the floor, around the transverse sigmoid junction at the back. So that gives you the first kind of prompt that this patient may be having a dural AV fistula if you see increased vascularity along the transverse sigmoid junction or along the anterocranial fossa base. You can again see some venous ectasia, microhemorrhages, and CTA will just show increased vascularity, but the actual diagnosis here is through a DSA. So that's called as the gold standard for investigations. And once you do a DSA, the focus here is to identify what is the foot of the vein. That means where the vein starts, because that will be your target either for open surgical approaches or endovascular approaches. The endovascular approaches can be through the arteries, like you can go through the MMAs, you can go through the occipital arteries, which are dilated and tortuous. So they provide you access. You can also do a pure microsurgical approach, which I will discuss. And we can also do a combined or direct approach where microsurgery is still involved. So whatever happens in the decision making, the most important part is to identify and read the DSA first, because what happens is when you see these daunting images, you will see multiple vascularities, and you will see in one run, you will see the arteries, you will see the veins, and you don't know where is the actual foot of the vein or where is your target vein which you want to target, either endovascularly or open surgically. So it's important to sit down and go through these frames, the angiograms frame by frame. And we always do a high frame runs to identify which vein fills up the first. And if you just let it play, it will obscure your vision and you will see multiple veins filling up and clouding your screen. So if you do frame by frame run, you will be able to see which is the first vein which comes up through the arterial connections, and that's where your target should be. So microsurgical access to DAVF can be direct surgical clipping or obliteration of the draining vein with the help of bipolar cautery. And if your CVR is caused by a vein which is single, which is easily accessible, then it becomes a proper microsurgical case. So when we discuss about these dual training, we always say whatever is most significantly easy for you as a surgeon to access. Can you do this endovascularly also? Yes, I think there are many radiologists who will try to do the dual AV fistulas. Every dual AV fistula is as simple as even the spinal ones through endovascular route. And that is where your training comes into the picture. When you see this from an unbiased view, you probably say this is more accessible surgically. The vein sometimes will be right below the bone, and why you will take significant efforts to go through wires and catheters and go to the venous side to multiple endovascular routes. So in my opinion, microsurgical access is very, very clear if you see the CVR is caused by only one vein, and that is the foot of the vein, which is straightforward, which is accessible, and it is close to the skull base. So let's see some examples. Now, this is one of the areas of dual AV fistulas, mainly along the anterior skull base. As you can see here, you can see this dilated vein, which comes up on CT angiogram, which looks like an MCA vessel. But if you go through and through again, you will actually see significant amount of vascularity along the skull base. And you see the foot of the vein, or from the area where the vein starts, is at the equilibrium plate. Now, when you do the angiogram, you confirm that finding. You can also see this is the ophthalmic artery, which will lead to ethmoidal arteries, which will be the feeders for these kind of fistulas. And all you will see here is the CVR. You will see that it is it's a big vessel basically seen on the right cerebral hemisphere, but the connection is mainly along the right cribriform plate. So when you do these surgeries, this is how the orientation is. This is the right-sided subfrontal approach. You can see the cribriform plate, you can see the skull base, anterior skull base approach, and you can see the falx on the midline. The important part in these surgeries is not how you reach to the area, is important when how you access it. So now once you have clearly seen that this is the foot of the vein, which is the cribriform plate, you need to either put a clip here or coagulate the vessel coming right at the junction of the arteries and the vein, and this is what we call as foot of the vein. So it's important to identify that you don't disconnect the vein away from the foot of the vein, because if, for example, this is also part of the vein, which you can see here. If you disconnect it here, the CVR will stop, but then this fistula will recruit something else from here, and the patient will have a recurrence. So it's important to know, as I said, where is the vein originating at first from the arteries, and target that area surgically. And for me, you can tackle this particular fistula through endovascular route as well. But as a surgeon, you know that subfrontal approach is very straightforward. It's relatively, risk-free. The important part here is to make sure that when you are lifting the frontal lobe to, to get to the cribriform plate, you are not actually pulling the brain up, and you go slowly relax your CSF, just like an aneurysm surgery. And once you do that, you'll be able to see exactly the brain getting relaxed and giving you the space. And then you have these small micro dissections to cut the arachnoid strands along with the vein. Sometimes I've seen if there is a nick in this blood vessel, probably the whole of the field will be completely filled up with blood. So it's important to be patient and work your way around these multiple tortuous veins, and your target should be where this vein is coming right from the bone, which is the foot of the vein. So when you do that, you will probably see and recognize your anatomy. You can do an ICG, and ICG becomes an important step here, because ICG will tell you where the vein starts to appear first. For example, you can see this is all part of the vein, the vein which is coming at the cribriform plate, which is initiating here, turns around, and then goes back here, and then turns back again here. So there are so many venous components, sometimes it can be confusing. And an ICG at that area, at that time, will help you to recognize where the contrast starts to fill up first, where the ICG is lightening up first. So when you can see that this is the skull base where it is, initiating at, it is showing up first, you know that that's your target area, and that is what we call as the foot of the vein. Once you do that, you will be able to see you'll be able to see the, oh, sorry, I think this is stopped. Let me stop it and restart it.
All right.
Yeah, I'm trying to open it again. I think the
Okay.
video froze. Okay. All right, I'll share my screen again. All right, so let me go back to where I was. Okay, so this was the case, and we saw the ICG. So this is the postoperative DSA, and you can see that there is still an ophthalmic artery aneurysm, which is a flow-related aneurysm in the orbit, but the CVR on the right side is completely gone.
Sorry, that did not share.
Oh,
UNI. Sorry. Once again, please check again. Thank you.
Can you see it now?
Okay, it comes. Thank you.
Okay. Yes. So you can see here the post-op angiogram. You can see that the CVR on the right side is completely gone, and you can still say there is a similar case where one of my colleagues was operating, and this is the cortical venous reflux, which you can see on the frontal lobe. And as you go down along the subfrontal route, you can see sometimes these can be a very big and tortuous veins, and you can see the foot of the vein is right at the skull base. And once you go slowly, patiently along the subfrontal floor, you can actually identify the vein. We can see here, this is the olfactory nerve, that's the claviform plate. Once you put a temporary clip, you will actually see the discoloration of the veins on the surface. You know that you are at the foot of the vein. Then you bipolar it, coagulate it with micro scissors, and you can see immediately the vein turns blue because there is no arterialized blood coming to the veins. Similarly, sometimes you can find small hyperarterial dual fistulas. You have to be very patient to disconnect all the arachnoid adhesions. When you are disconnecting the arachnoid adhesions, you are basically isolating the vein. Once you see the veins very clearly, you actually coagulate it. Make sure that you are actually just targeting the foot of the vein, not the other veins, which are simply draining, and then cut it with the micro scissors. And again, you can use an ICG to confirm that the vein which was seen here does not come in the arterialized phase. This comes up in the venous phase. So you can see the ICG will come up immediately. You will see the arterialized phase now, but the vein does not fill up, and it will only fill up in the late venous phase. So that tells you that you have disconnected this fistula and you are not redirected into any other veins which can be seen. So the key points here is, as I said, to read the angiogram first. I don't think so this is technically as challenging as, for example, clipping an aneurysm, but to identify the foot of the vein, to use ICG to delineate which part fills up first, slow, gentle bipolar coagulation. I keep it around 5 so that it does not shrink the vein immediately. Keep your bipolar in the lower settings, as I said. Make sure you have both the edges of the vein, copious irrigation, and clip-based placement is an alternate option if you can see. But I don't do it because I can sometimes cause artifacts in the post-op CT. Now, there's another approach where you can find it useful if suppose you have an isolated fistula which is directing towards the orbit. Sometimes you can do a transcavernous approach. For example, this is a patient with a 71-year-old female present with isolated left eye redness and proptosis. For 4 months, there were no cranial nerve pulses. On the CT angio, you can see this is the superior ophthalmic vein which is going towards the left orbit, and you can see there is significant proptosis on the left side. So you identify that on the CT angio, and when you do a DSA, you will clearly see that there is this fistula which is indirectly into the cavernous sinus and is kindly only redirected towards the orbit. So there's no rest of the CVR seen in the brain, but your orbit is completely proptosed, and you can see the eye is bulging because of the venous congestion. So in these situations, which is not very common, sometimes you can have a direct transcavernous approach. Through endovascular route, this access was not possible because she had no clear access through the inferior petrosal sinus or from the facial vein. So we went through the transcavernous route. This is a middle cranial foci approach. This is a pretty standard approach for our microsurgical approaches. You can use an ICG and you can see where actually the venous pouch is. So this is the foot of the vein, for example, here, and you can clearly see it's between the V1, V2, V3 segment. And once you identify that with a Doppler again, you will put a direct needle into it. And once you see the arterialized vein coming back, you can either coil it with the help of a microcatheter, or because we were just there and it is so localized into the orbit, we injected thrombin and coagulated that completely. And you can see packing with Surgicel. So you can actually localize clearly based on ICG and directly inject thrombin as well. So post-op angiogram showed there was complete occlusion and the proptosis and the superior ophthalmic vein was disappeared on the post-op angiogram. So we published this in Operative Neurosurgery, which was very rare, but it's an approach. Lastly, when we use a direct or hybrid approach, this is used when we have a sinus which is completely isolated. So you cannot have access through the venous side, you cannot have access through the arterial side. then in that situation, again, microsurgery comes into the picture, which is called as transcranial approach. Has been described in these cases. For example, this was a 45-year-old patient who presented with remote history of hemorrhage and just came with headaches. When on the MRI, you can actually see their previous hemocytin depositions. That means there was some remote hemorrhages as well. CT angiogram, as I said, will just show increased vascularity along the transverse sigmoid junction. You don't know what that is, so that's why you will do an angiogram. And when you see this angiogram, you can see here the ECA vessels which are supplying directly this segment of sinus, which is completely cut off from the venous side, proximally and distally. So this is what is called a sequestrated or isolated sinus. So what's happening is the arterial blood is coming from the middle meningeal artery going to this sinus, and everything which you see here is the CVR. This is all the corticovenous reflux, which is causing venous hypertension. And you cannot reach through arterial route, you cannot reach through the venous route, and that's why the surgical access becomes an important part. So you take this patient, if you have a hybrid OR, or you plan this patient in surgery first, take the patient intubated down in the cath lab, make a small opening on the sinus, put a small catheter, and you coil that together. So we took the patient first to the OR, used the navigation to localize the sequestrated sinus, did the craniectomy because they usually bleed a lot. So craniotomy is not an option. You do a craniectomy and bone wax all the ECA feeders which you come along your drilling. And once you have clear identification, then you take the patient intubated to the angio suite and identify that sequestrated sinus, put in a microcatheter, and coil that through microcatheter. So it's another similar patient which I did when I was in India. This is a similar patient with severe headaches. You can see this is the site of the foot of the vein, and the blood is going retrogradely into the supracismal sinus, and all the CVR is coming from this focal point. So as I say, the DSA can be very daunting, but as soon as you see and you read the DSA frame by frame, you see that the fistula, all this blood is actually coming from here. So this becomes your target, not all of these veins. So once you do that, you basically you can attempt a transarterial route, which I did, which failed, of course, because these are transosseous channels. So the liquid embolic agent will never reach to the fistula side of the foot of the vein. Then you did a combined approach. So we did a craniectomy, and we did a direct installation or puncture of this part of the sinus, and you just needed packing of the coils in this short segment of the transverse sinus. The rest of the CVR was gone immediately, as you can see here. So to conclude, I know the endovascular approach is the first modality of choice for cranial dural AV fistulas because they are very complex, sometimes not surgically accessible. But microsurgery is a very, very helpful adjunct for sequestrated sinus, or as a primary modality, if you can see that you can access the vein directly and in a very, very simplified and clear way. If it is single, if it is along the anterior skull base, or if it is along the transverse sigmoid junction, when you can see a single vein, which is starting point of that fistula, then you can take the patient for surgical surgery also. Neurosurgeons, as I said, should master the knife and the catheter, decide what's the best for the patients. And in my opinion, if I see something which is very straightforward, surgically, I take the patient for surgery. If I see that the vein is very deep and it will be difficult to go through surgical route, then I take the patient from endovascular route. So that will be it. Thank you so much for your kind attention.
Thank you, Professor Kamara. Some fantastic cases. So doing the surgery for the dural AVF is so difficult, challenging sometimes. So, but you mentioned this so clearly into how to manage, how to operate the patient with a difficult case of dural AVF. Thank you. So single drainer is very, very important to try to occlude the open craniotomy. So first step to try to perform this surgery. Thank you.
Thank you, Professor Kimura. As I said, I think the surgery becomes relatively straightforward if you understand the angiogram. So I think part of it, when my fellows do these angiograms, I ask them to go back, do not, give me the answer on the same day, read about the angiogram again and again, and then say where is the fistula, where is the access point, if it is straightforward for surgery, or if it's very complex, it will take endovascular route. But reading the angiogram, I think it's part of the surgery, and that's very important. I think that's the most important point. When you see multiple fistulas, where exactly the fistula is originating and what's the foot of the vein, I think that becomes most important.
Yeah, I totally agree with your comments. So before that, we have to read the angiogram in detail preoperatively. Very, very important. Do you perform the three-dimensional angiography preoperatively?
Yes. We do 3D dimensional angiography, but I find that is not very useful in dural fistulas, because when the spin comes, you will see the veins and you will see the arteries together. But sometimes time-resolved images can show you which is the artery, which is the vein. But again, everything fills up so fast, then 3D sometimes becomes difficult to interpret. So what I do is I do a six frame angio. So all the angiograms become 6 frames. So you will clearly see the dye, traveling slowly, and which each frame you can actually see what's the entry point, where is the vein coming on. That becomes more useful in my opinion. But yes, we do 3D spins for all these patients.
That's right. That's a fantastic comment. Thank you. So is there a comment, Professor Dilishod? Do you have some comment? Thank you.
Thank you so much, Professor Shishkumar. Yeah, that's a very interesting topic. Yet it's very, in my opinion, underdiagnosed. There are many underdiagnosed cases. So regarding in diagnostics of the dural AVFs, what kind of tips you can give to young neurosurgeons? Is there only predisposed factors if the patient had neurotrauma, or if the patient had some kind of other problems which are proning the neurosurgeons to do DSA, or there are clear complaints that are needed to be evaluated through angiography?
Thank you, Dr. Dilishod. So most of these patients will present either with hemorrhage, or they will present with seizures, or they will present with headaches. So these are the 3 most common symptoms which we see with dural AV fistulas. The last presentation is completely incidental. So they will do a scan for something else, and they will find increased vascularity in one area of the brain, either in the subfrontal region or along the transverse sigmoid junction. And then that will initiate the workup. But most commonly, they will present with either remote hemorrhages or acute hemorrhages. They will also present with seizures because of the previous hemosiderin deposition, like cavernous malformations, and sometimes they can be incidental. So for me, if we see any kind of increased vascularity on a CT angiogram, which is done for some other reason, or because of the headaches or seizures, if you see that there's increased vascularity, I think you can suspect there's a fistula, but you can never diagnose it on MRI or CT angiogram. So the diagnosis is always through DSA. So if you should keep a low threshold for doing a DSA on these patients, if someone is presenting with severe headaches, someone is presenting with seizures, or you just see an incidental hypervascularity in particular area. So if you see that, you take the patient to the angiogram. That's where the diagnosis is formed. Because if you leave it alone, as I said, the annual risk of rupture is around 8 to 10%. It's much higher than an aneurysm. So the threshold for DSA should be low. So that will be my message to the young neurosurgeons, that do DSA, even if it may come as negative, but if you think that there's increased vascularity and the symptoms match, then take the patient for high frame DSAs and do all the runs in 6 frames so that you can identify where the vein starts. Thank you. Thank you for your question.
Yeah. Okay, now, Professor Ericon, do you have some comment? Professor Ericon?
Dr. Sam has a question. I'll follow, but thanks for asking. I'll follow after Sam has asked this question.
Okay, thanks, Prof. Kimura and Prof. Irian. Fantastic and eye-opening talk, Prof. Kumar. I would like to ask regarding the case of carotid cavernous fistula. It's quite a common case. What was it in particular for that case where you decided to do it microscopically? That's one question. And I would like to clarify, when you showed the video, you did the ICG, you injected thrombin into the cavernous sinus. Is that correct? Yeah,
Correct.
and the last question will be, will there be like any risk of thrombosis in other parts of this one? And it was very interesting. I would really like to learn how you did that and how you chose the case, because we have it quite common here in my part of the world. Thanks.
So that's a very good question, because again, we go back to the DSA, right? So once you see the DSA, you will actually recognize whether the CVR is going to the rest of the brain or it is going very, very focally towards the orbit. So the only reason we reached that, microsurgical approach for that patient is because we saw on the DSA that the foot of the vein is in an isolated part of the cavernous segment. For example, when you see a lot of indirect fistulas, you see the flow going into the rest of the veins in the brain. Then you cannot use this approach, because whenever you will inject anything or you will put a coil into that sinus, you will probably, kind of throw the thrombin particles all over in the cerebral vein. So patient will have a high risk of venous infarcts or venous hypertension. Here, this case was so different. The fistula was only directed towards the superior ophthalmic vein. And that's what the DSA comes into the picture. You could see through the runs again and again that the fistula is only directed to the SOV. For example, you can do a hybrid approach in this case, right? So you have exposed it, you put in a small microcatheter, and you can put a coil in as well, right? So it will also obliterate that pouch, which is I call as foot of the vein, easily. But because we were right there, and I knew that this is only going to the ophthalmic vein, which you actually want to obliterate, you can actually use a thrombin at that point of time, and you can occlude it immediately. Can you use coils in that situation? Yes, you can easily use coils. But again, this was, I think, a low-cost initiative, because we knew that this fistula is only restricted to the left orbit, and the veins are not going anywhere in the brain. If the veins were going anywhere in the brain, then you will probably just put a coil into it, because the coils will not travel anywhere else, and it will completely obliterate the part of the vein where it starts, which is the anterior cavernous segment. So this you can call in a way is a sequestrated and isolated cavernous sinus. It's not the usual fistula where you see the whole sinus is filling up. Sometimes the opposite sinus is also filling up, and you see a lot of CVR. So this is an isolated case. And even in this case, we tried to go through the inferior petrosal sinus first endovascularly. Then we tried to go through the facial vein, because these are less invasive routes. But when we ran out of options, then we thought, like, why not surgical approach becomes a good option here? Because on the CTA, you can actually see the vein very close to the superior orbital fissure. So if you go through your standard middle penile fissure approach, you can actually approach that pouch directly. And again, this is like, after you tried everything else, then this became your backup option. Just because it was so isolated, you could inject thrombin, but you can do if you think that it's kind of the veins are going to the rest of the brain as well, then I will just put in a small microcatheter, and I will just put coils into it, because coils will stay there. They will not go anywhere else, and it will occlude the foot of the vein.
Right. Thank you so much for such a detailed answer.
Thank you.
Dr. Biswas, you want to answer? You want to ask your question?
Thank you, sir, for the opportunity to ask. Sir, excellent presentation. I have few questions, sir. Number one is the intracranial based dural fistula. What do you advocate, microsurgery or endovascular, irrespective of ruptured or unruptured? This is number one. And number two, sir, transcranial access to venous sinuses. What type of vascular access sheet you use in that case?
Thank you.
And number last question, sir.
Go ahead. Yeah.
Sir, that fistula only connecting to supraophthalmic vein. Was there any scope for direct puncture of the supraophthalmic vein and do the embolization?
Thank you. So the first question was, if you remind me, the first question was regarding the...
I mean, intracranial based dural fistula. What do you advocate, either surgery or the endovascular?
So if we see that there is a anterior floor fistula, that surgery becomes the first treatment of choice, because as I said, the target is the vein. So how you can access the vein first and most simpler manner, because we are surgeons, we can do both, right? If you ask this question to a radiologist, they will come through the venous side and they will take a longer route to reach to the same area, which you can reach in probably 20 minutes, isn't it? So if you are doing the subfrontal approach, this is your approach for all the meningiomas which you do, all the kind of approaches you do. So for you, it becomes a straightforward approach. For me, I not even think about endovascular approach in this situation. I'll directly take the patient and I will do the subfrontal approach, ruptured, unruptured. It's a more straightforward access for me. So for anterior fossa, always surgery, microsurgery. For transverse sinus fistula, which are more common, endovascular approach is the first approach, because this is a very vascularized area. And unless you are seeing a single vein coming out the transverse sinus, then you can do surgical approach as well. But usually along with transverse sigmoid junction fistulas, you will see multiple veins coming. As I showed you in the example, they are not one vein. They are like 3 or 4 or 5 veins coming through that part of the sinus. And then it's not a good case for surgery, because then you will have to take each vein individually. But by the time you take each vein, you will have so much of blood loss because that area is heavily vascularized. So for transverse sigmoid, endovascular is first route unless you see a straightforward vein, single vein coming out of it. And the third one which you asked is what kind of micropuncture sheath. So if you are doing a direct access, and I have done now at least 6 or 7 cases over the last 5-6 years, it's not very common because most of them can be treated either with surgery or either with endovascular route. But if you have like a sinus which is completely cut off or sequestrated, you use a 4 French microangio sheath. So there's a 4 French microangio sheath. You take the patient to the OR, or if you have a hybrid suite, localize that with ICG, and you will see where is the sinus, and then you puncture that with a 4 French sheath and use a one-way stopcock, and then take the patient down and then open through it and put a microcatheter to it and just completely coil the diseased sinus. So 4 French works the best, and it's small enough that you don't have a lot of blood coming out when you puncture it directly, but it's also big enough to allow your microcatheter like SL10, for example, to put coils in. So 4 French all the time for direct access.
Okay, I have one question.
Go ahead.
Direct puncture to SOV. That case you showed.
So again, direct access to transorbital route is an option. We went through the facial vein route, and we found that the facial vein was stenosed, so we could not access. I think we reached up to the inner canthus along the angular vein, but we could not reach through to the site of the fistula. So the other options are sometimes direct transorbital puncture to the cavernous sinus, or through an ophthalmic open access. So we also got ophthalmologists with us, and sometimes they can do a cut down and they can actually sling the SOV for you so that you can put a microcatheter and coil it. So when I see that this becomes more complex, I will then think like, okay, can we access it surgically? Because normally we don't think surgery for dual AV fistulas. So we'll have to think out of the box here. And when the ophthalmic surgeon was not confident that he'll be able to take the SOV because SOV is not that big, then he said like, if you can access it surgically, it's a good option. So it's always good to have multiple options in your, kind of armamentarium and choose whatever is necessary. So we tried endovascular, but I will not keep on trying multiple ways of doing it if I see that surgery can be an option. So it's not very commonly we do direct transverse cavernous approach for these ones, but in the literature, a lot of people are doing, and sometimes they can actually, if there's a single cortical vein, they will do a burr hole on top of that vein, and they will put a microcatheter and just coil that vein. So, and you can see that on a lot of other papers where the surgeon is the main deciding factor. If you are asking with a radiologist, they will obviously do it without surgical route by one way or the other. But for me, it's whichever is more easier and straightforward.
Thank you, sir. Sir, your last line encouraged us. say the neurosurgeon should hold the seizure and the catheter, and we also follow that, sir.
Yeah, I
Thank
know.
you.
Thank you so much, because this is where you will, not try to just use one way to think about it. Once you have both the options, that's how I will say that you are different from the radiologists. And I remember when this case was published on Twitter, I actually kept on my last slide, then I removed it. A lot of radiologists will say, and I've seen in the comments that there is no CCF which will require open surgery. Like comments like this, like there is no CCF in this world which will require open surgery. So blatant statements like these make you, keep doing these things more often, because then you are actually challenging them. They will say like, well, you can send the patient to Sydney, for example. One of the comment was this: in Australia, we will try to pass a catheter, pass a wire, we'll make it happen. So for me, it's more like, whatever is straightforward, safer, easier access, and I have both the options. So as I said, master knife and catheter, because then you can choose your patients and indications.
Exactly, sir. Thank you.
Thank you.
Thank you for nice talk, and thank you for the excellent comment.
Thank you, Professor Kimura.
Yeah, thank you. Is there any comment or question from audience? So, Professor Yokato, do you have some closing remarks included?
So what about the Arian? Do you have any comment or?
Thanks. Yeah, thanks, Professor Kato. Dr. Kumar, you continue to be a surprise of a dual-trained neurosurgeon that never stops mastering the skills of the scalpel and the endovascular techniques. It just goes to say that it's best to know both ways when possible, so you can offer to your patients means of choice, rather than being limited to only endovascular. And you have proven through hard work to be one of those physicians that now are considered for many years a neurosurgeon of choice when that options is there. So it's always great to have you with us. At the same time, you offer that answer to the question, is it best to be one or the other? I think it's best to be both. Be both an open vascular and an endovascular surgeon. So it's wonderful. Your work goes to say that the reality is that. So thanks, Dr. Kumar.
Thank you so much for your comments.
So, Dr. Ashish, maybe some small space for radiosurgery for the dural ABF? If there is, and what is the indication?
So there are some case reports and case series which are published for radiosurgery for dural fistula. People have done it, and I think Dr. Konziolka has a big series for radiosurgery for fistulas as well. But there are certain indications. But for me, Professor Kato, when I see this, even an unruptured fistula, I'm looking at 10% rupture risk. So I personally do not prefer it. I mean, radiosurgery, I have opted for AVMs because they have 2 to 4% annual risk. But here I'm looking at 10% annual risk of rupture and morbidity. So I don't even give that option. I tell them that there is an option. If you want to explore, please, speak to a radiation oncologist. But I personally prefer not to send these patients for radiosurgery. AVM, yes, but AV fistula they can bleed, in the next few weeks or days or months, who knows. So I personally do not prefer, but yes, it's a recommended tool, and there are some excellent case series published on this. And I think none of yes, sorry, Professor. Yeah. None of my colleagues also refer.
So many aged patients in Japan, so that's why.
Yes. Yeah. For certain age categories, I think this becomes an option. If they don't want to pursue either endovascular route or surgical route, then radiosurgery is an option for that particular group. Yes, that's always there.
Thank you very much. Anyway, congratulations on an excellent talk.
Thank you, Professor.
So maybe thank you. Dr. Ben?
Yes. So if there's no further questions, then it probably come to the end of our section. And so on behalf of Professor Katos, and I would like to thank you all of you for joining us today to our ACNS YNS webinars. I would like to thank for the chair, Professor Kimura Sensei, and also our speakers, Professor Liu Yujun, Professor Samsu Arfini, and also Professor Ashley Kuma, and also our discussant today, Professor Dilshot, and also Professor Arion. And also our moderators today, Sachin and 𝑑𝒓𝒐𝒄𝒄, and also Sukherti. And thank you so much for your help to moderate this section. So I also want to thank you for all the audience today for joining us today. Today we are really having a very wonderful and fruitful vascular day, and we learned so much advanced technique from all of the three speakers. And I would like to say thank you to all of you for joining us today, and I hope to see you all next time. So it's a bye-bye to all.
Dr. Ben, maybe Dr. Pawat from Afghanistan.
Yes, sure.
Maybe some.
Any comment from you?
You want to say something? Yeah.
Okay, thank you. It's a great webinar, and thanks very much. As you mentioned, we learn a lot about you and our professors, especially from Ashish Kumar and other presenters. Thank you very much.
Yes.
Thanks so much.
And I can also see Sachin is here.
Yeah, Sachin.
Hello.
Hi, Ben. I was just silent and listening to all the three lectures. And when Ashish started the lecture, he said it's least technically challenging. But I think you are the best example of the best hybrid neurosurgeon. All those people who are saying that no opening for dural AV fistula, they are jealous of you that they can't open. That's why they make that statement. You, as you said, hold the catheter and scalpel in the hand. So that's the best way. At the end of the day, the patient should be better. That's what matters.
Exactly.
So congratulations. I'm really impressed by your presentation today. Thank you very much.
Thank you, Sachin. Thank you.
And I think Professor Kuma is always a model of a dual-trained vascular surgeon. So, and thank you.
Excellent. Thank
And
you.
thank you to all of you. And I really love to see all of you come together here. And thank you so much for joining us today. So if there is no further comment, then may I end this session, and I hope to see you next time in our ACNS YNS webinars. And really wonderful day, and